Great. Okay. We have live feed. This is great. This is my first time actually getting the Google Hangouts to work, so you're going to have to bear with me. I hope you guys didn't get fed up and give up. Okay. I'm just going to start screen sharing and jump into this, and hopefully we will get some people watching, and this will be awesome. All right. Okay, great. You can see my slides. So let's see, make sure you can see everything. Okay, great. So let me make this a little bigger for you. Okay. And there we go. All right. So the title of this broadcast is How to Hack Healthcare, 7 Cardiovascular Silent Killers, What You Need to Know. Because there's a lot that can kill you out there, but some of the top killers are cardiovascular disease. And unfortunately, though other things might have symptoms, cardiovascular disease sometimes doesn't. And the only way you know you had it is when basically you're dead or you're in the hospital or you're disabled, which is really scary, if you ask me. And so I thought it was very important to make sure that everyone got this information, basically, for the different cardiovascular killers. So bear with me 1 minute. Okay, who am I? If you're watching this on Google Plus or YouTube, you probably have gotten an invitation or saw it on my stream, so you know that I'm Die Cleverly. And what you might not know is that I have 20 years experience doing education for doctors, nurses, and pharmacists and patients, and I love doing patient education. So I really want to make sure that everyone gets this information. Today we're going to discuss cardiovascular silent killers. You may also not know how common cardiovascular disease is. Did you know that 83.6 million people have blood vessel disease, which is mostly what we're going to be focusing on today, and 77.9, so almost 78 million people have high blood pressure, which is a really big number. And of that, 17.2% don't even know they have it. And another percentage is uncontrolled. So there's a lot going on with high blood pressure. I'm going to start off with, I'm going to show you this slide as well, with explaining to you what hardening of the arteries is, because this is kind of at the heart, so to speak, of most of the problems that we have today and that we're going to be talking about today. So hardening of the arteries, they sometimes call it atherosclerosis or arteriosclerosis, but it's basically stiffening up of your arteries. Normally, your cholesterol level should be below 200. And on the slide, I have some other various numbers that are good to target for. Lots of people, however, do not meet that goal. I mean, a normal American diet or a British diet, would tend to keep that cholesterol higher. What can happen is that when there is cholesterol, very particularly the LDL and the VLDL floating around in your blood, they can actually start coating the sides of your blood vessels, and you get this big giant glob of cholesterol. That in itself is not as bad. It's the effect that it has. It narrows the artery, so blood flow, it's harder and harder for your heart to pump the blood, and that's when the blood pressure goes up. It also does some other weird things. It really makes your body angry. Your body does not like to have cholesterol coating the inside of its arteries. So it sends in the troops, which are these inflammatory white blood cells. They're macrophages and T cells. And they try as they must to eat up all the nasty fat, but then they get so overstuffed, they get lodged into that plaque themselves, and they become something called foam cells. There's also calcium and smooth muscle cells and fibrinogen that gets formed. And that plaque is constantly in between either being stable, which means nothing really bad is going to happen except making your blood cells narrow, or unstable. And if something's unstable, then it means that it can break off, and then blood cells rush over to try to help, but they actually make things worse, and they make a big fat clot, and that big fat clot can actually go and cause some of the things we're going to talk about. So I hope that sufficiently explained what's so bad about high cholesterol in your arteries. So as I said, if you stiffen up your arteries, you're going to get high blood pressure. There's other reasons for having high blood pressure as well, but that's definitely a side effect of having stiff arteries. When they measure blood pressure at the doctor's office, you always get a number, right? So it's like 112 over 78. That top number, that's how hard your heart has to push when it's beating, right? So that's the pressure when your heart is beating. It's going, and that's the pressure. The lower number is kind of when your heart's not beating. So in between beats, it's like the more natural flow. And some people tell you systolic is more important than diastolic and things like that. However, what they're finding out now is there's been a lot of emphasis on something called pulse pressure. Now, pulse pressure, you are never told that at the doctor's office, but if you get your blood pressure, you can figure it out yourself. You just take the top number and you subtract the bottom number. The best thing is if you have it in between 40 and 60. If you have it above 60, then you probably have stiffening of the arteries or atherosclerosis. If you have it below 40, it might not necessarily be bad, but it might mean you have leaky valves or a weak heart. So you can do that quick calculation yourself and then ask your doctor, oh, I noticed my pulse pressure is above 60. Are you concerned about that? And find out what he or she thinks. High blood pressure is also called hypertension. So you might see it referred to as hypertension. And unfortunately, because this is kind of like the title of the talk, it doesn't have any symptoms in most cases. So you could have high blood pressure and not even know it. And a lot of people do. The normal is less than 120 or less than 80. And you start having pre-hypertension up to about 139 and 89, and then it becomes high blood pressure after that. However, if you have diabetes or renal disease, you have to be really careful because you have to keep that blood pressure really low. About 130 over 80 is the guidelines. So below it, below 130 and 80 are the guidelines, I should say. Okay, I'm going to show you another one of my slides. Here you go. And this is about understanding stroke. So one of the things I was talking about, the cholesterol and the high blood pressure, is because we get to one of our first real killers, killers, is stroke. Stroke is pretty common and pretty commonly known. People know, oh, so, you know, what a stroke is. But most people don't realize that it's actually two very, very different things are referred to as stroke. So you can have something called an ischemic stroke, where you've blocked the blood flow and you have death of the brain cells due to blockage of the blood flow. You can have hemorrhagic stroke, which is uncontrolled bleeding, which seems to be the complete opposite, but it leads to the same effect. You have death of the blood cells. And on the right, I've also put some symptoms of stroke. I just also wanted to mention, we're going to talk about transient ischemic attack in a second, but 15% of ischemic strokes are actually preceded by transient ischemic attack. And one of the ways you can tell if you're at risk, if you're told, or your loved one, your parents, or someone in your family are told they have been having TIAs, take a look and make sure they don't have these risk factors, which are that the symptoms last greater than 10 minutes, their speech is impaired during the TIA, they have extreme weakness during the TIA, or if they're just greater than 60 years old. Those are the people that are most likely at risk for it becoming ischemic stroke. The hemorrhagic stroke, that can bleed in two different places. There's the intracerebral, which is kind of the middle of your brain, and then subarachnoid, which is kind of under the top of your brain. And those are two different places, and they have two very different types of symptomology. The next slide will tell you about other forms of blockage of blood to the brain. There's the silent cerebral infarction. This is not something that most people know about. It is actually something they only find on MRIs and CAT scans. And the thing is that it actually will increase your risk for symptomatic stroke. It's kind of like having a TIA without any symptoms of a TIA. So there are little pieces of brain that get killed off that you just don't have any symptoms about, but something's going on. It means something's going on in your brain, and now you're at risk for a symptomatic stroke. And the TIAs, which we talked about earlier, are also known as warning strokes or mini strokes, but there's nothing small about them. They are truly a warning that you are at risk for stroke. And unfortunately, 11% of people who are experiencing TIAs go on to have a full-blown stroke within 90 days. And then absolutely terrible is that 12% die within 1 year of having the TIA. And that's one of the reasons why they have to be taken seriously and really be looked at and correct the problems that are causing the TIA. And of course, there's recurrent stroke, which means once you've had one stroke, you're now at a higher risk for having another stroke. And in most cases, that risk is higher the first year after the initial stroke. And it really depends. The greater number of risk factors you have, the greater your chances you're going to experience recurrent stroke. Okay. So I love this graphic, which really gives you kind of this overall feeling of all the stuff that's going on with stroke. And I'm just going to call out some of the key things, okay? One of which is most people have no symptoms until the stroke happens. I mean, it's just terrible. And very shocking. And you have, it's the fourth leading cause of death. On average, someone dies every 4 minutes of a stroke, but yet 80% can be prevented. And a large number of younger people, it's not all people over the age of 65 that experience strokes. Also, it costs, in America, it costs us $73.7 billion after someone's had the stroke. Think about it. If you have risk factors of stroke and you're thinking, I don't know what they are. So basically, genetics actually comes into play. You have a 50% higher chance if you have a relative who's had a stroke, high blood pressure, which we talked about, diabetes, which we talked about. And then there's another thing we haven't talked about yet called atrial fibrillation. This is an irregular heartbeat. People, just like I showed with that blood vessel where the blood flow gets kind of messed up, in the heart with AFib, the blood flow also gets messed up. Whenever you don't have blood flow in a straight line, but you have these eddies inside the blood vessels, it can cause a clot. And a clot is a really bad thing. So the clot is the thing that can go up and cause the ischemic stroke, if you remember. I want to kind of tell you a little personal story since I have a little extra time than I usually have in my videos. So I have a family member, someone who's, involved with our family by marriage, and his mother had atrial fibrillation, and she was not compliant with medication. She did not want to take the medication for it. She ended up having a stroke. And the worst part about it was not the stroke. The worst part was that she was put on life support. So she didn't die, but she was on life support, and her chances of coming back from the extent of injury and, being able to function again was very, very low. One of the brothers, the older brother, decided to end the life support. and it was his decision legally, but the younger brother was really angry about it, and it ripped the family apart. And it was just such a horrible thing to see. So the risk of stroke is not so much the death, but it's also those type of things that can happen. So stroke can be absolutely devastating to families. Another risk factor is sickle cell disease, and also lifestyle risks, which it's the same story throughout this entire hangout. It's going to be poor diet, so lots of salt, lots of fat, obesity, smoking, very bad, high risk for strokes, and lack of exercise, and hormonal birth control can be associated sometimes with stroke. That's not that common, but thought I'd throw it in there. Okay, stroke hacks. So we don't want to have strokes, right? We just don't want to have them. They are somewhat preventable. Get your cholesterol under control. Start some form of exercise. Quit smoking. Get your parents to do these things as well, and cut out salt, fat, and alcohol. You don't have to cut out the alcohol, but just cut it down. And I'm going to show you another thing. This is the mnemonic for if you're with someone, they start acting strange, they have these risk factors, do this test. It's called FAST. And I'm going to show it to you right now. Here you go. So FAST is a really neat mnemonic that the Stroke Association uses. And basically what it is the F stands for facial drooping. So you ask the person to smile, and if they have this lopsided, funny smile with one eye down and one part of their mouth unable to raise, then your suspicion goes up. Then ask them to raise their arms. That's the A in FAST. If they have arm weakness, they cannot raise their arms. And if they have speech difficulty, so all of a sudden their speech has become slurred, they're highly confused, they can't talk, then it is T, time to call 911 and get these people to a hospital and get this checked out. This is something serious is going on. So that's your FAST. Okay. Hold on one second. Sorry about that. There we go. Whoops. Okay. We're going to move on to our next silent killer. This one is not as well known as stroke. It's called peripheral artery disease, or PAD. This is, a lot of people realize that your heart arteries can become clogged, and that can lead to a heart attack. But did you realize that the arteries in your legs are really quite large, and that they also can get clogged with plaque, and this can lead to disease? And it's also, if your heart, which is coronary artery disease, is getting clogged, then your legs can also get clogged. So I'm going to show you a picture here so you get the idea. Here we go. So now you can see that, normally blood flow is back and forth with the legs. And then if your arteries in your legs are getting clogged up with plaque, then you're going to have the same problems of poor blood flow. And sometimes even your doctor will even say, oh, you have poor circulation in your legs. It's really actually peripheral artery disease, and you should probably have that more grown-up discussion with the doctor and say, is this peripheral artery disease? Is this putting me at risk for something? Can we have a discussion? So the other thing is this can be completely symptomatic. 40% have absolutely no symptoms, even with severe blockages in their legs, until something really bad happens, which we'll talk about in 1 minute. Occasional pain with walking, and that's called intermittent claudication. That's where you get a pain in your leg from walking, and that's about 10% of people. And then 50% have these other weird symptoms, discoloration. If you have sores that are having a really hard time healing, and you don't have diabetes, which is another reason for all of that. But if you don't have diabetes, but you have these sores that can't heal, you might want to find out if you have PAD. And also, these blockages in these artery legs can cause erectile dysfunction, particularly in men with diabetes. So this is really interesting to me. A lot of these other things are you can see a difference in the countries, but this one is just so dramatic. In Southeast Asia and the Western Pacific, where there's low income, there's a huge number of people with PAD. The reason for this is smoking and kind of smoking and diet and low health. Then in Europe and the Americas, it's varying degrees of people have it. And then the Mediterranean area, which has one of the absolute best heart healthy diets in the world, it's extremely low. So they have the best incidence. And this also, the other key point of the people under 40 can also have PAD. And so it's not just limited to older people. And that's a lot of these diseases are much more prevalent and higher risk in older people, but this one in particular can be found in everybody. This is what can happen when you have PAD. And unfortunately, if this happens to a bad degree, and if you get a bad sore and lack of blood to your area, you can get gangrene. And it's not just an amputation, but if you've gotten so bad, your PAD has gotten so bad, you need to get a limb amputated, there's a 50% mortality rate for those people after about a year, I think. So it's a pretty serious disease. Another thing, similar to stroke, but even more intense, is that if you have a relative with PAD, you have an 80% higher risk of PAD. So just keep that in mind. You know, if mom or dad have PAD and you have to get them treated for that, that may mean down the line you have it. So you can take preventive measures early. It's a great take-home message for you to see if you see your relatives going through this. And then the risk factors are always the same. It's cigarette smoking is the absolute highest associated thing with PAD. Diabetes is very highly associated. High blood pressure, high cholesterol, obviously, high homocysteine and cystatin C, which are two markers, and obesity are associated with PAD. And not only can PAD lead to amputations, mortality, problems with your feet, it's also associated with other cardiovascular diseases, which are quicker killers of people, like heart attack and stroke. Okay. So what do you do about PAD? I mean, it's there's very few symptoms, and you could be at risk for it simply from having someone in your family with PAD. So basically, you could ask your doctor about getting screened. They do have screenings for these, and we'll talk about that at the end of the program. So if you're 70 or older, if you're 50 and you have a history of smoking, or if you're younger than 50 and you have diabetes and other risks and indications of atherosclerosis. Prevention is best. That's why I said earlier, if you know you have a relative who has diabetes, then, get on the prevention. I mean, a relative who has PAD, get on the prevention train immediately. Change your lifestyle habits. Stop smoking. That is the really highly associated one. Exercise and eat right. And then you can also control diabetes, and high blood pressure. So those are two other risk factors that can be controlled. Have your feet checked often for sores or discolorations, even to the point of if you have PAD or your relative has PAD, make sure they get their feet professionally checked. There are doctors, podiatrists that will check the feet and make sure these things don't get out of hand so you don't end up with an amputation. And treatments might be cholesterol lowering medications. They can also do, if it's really extreme, bypass grafting, just the same as they do with the quadruple bypass with the heart. They go down there and they do bypass grafting on your legs. There's angioplasty, where they do the rotor-rooter and clean it out, and drug-eluting stents put in there to keep the blood flow, and also anti-clotting therapy. So there's a lot of different ways that they can combat it if they know you have it. That's the hard part on these things that don't have symptoms. Okay, so here's another one that's just super scary and not known, but just everybody needs to know about this one. This one is absolutely the one thing that I hope everyone takes away from this broadcast is that this is it. This is called aortic aneurysm. Okay, and this one just, oh, it's just scary, scary stuff. So what's an aneurysm? An aneurysm is, quite frankly, a bulge, right? So it's a bulge, and the aorta is one of your largest blood vessels. So you put them together and you see that you can have this giant bulge in your blood vessel, right? Your aorta, this giant blood vessel that's running down the center of your body. So because it's so big, then it goes down there. They've actually broken it up into two different types of aneurysms. You have your thoracic aortic aneurysm, which is the higher part. Let me see if I can do my mouse here. I don't know if you'll see it, but it's the higher part, the top one there. It's labeled B on the diagram, and that's the one that goes right near your heart. And that's the thoracic aortic aneurysm. And then there's the abdominal aortic aneurysm, and that's the one that runs below the kidneys. And then there's some that are kind of in between that are called thoraco-abdominal aortic aneurysms. So what happens with these is that it's much more common in male smokers, and again, with a family history. So all these things you see have a family history, and people with a connective tissue disorder, which are relatively rare. But the incidence, of course, because it's associated with smoking and age, the incidence is rising over the past 4 decades. So what happens is in the older groups, age groups, you'll have 12.7 in the UK, 12.5 in the US, and Norway's a little bit better off with 8.9%. So think about that. That's about 1 in 10 people are at risk, particularly men, particularly smokers, and if you've ever smoked. It doesn't matter if you've quit. This is one that having ever smoked puts you at risk for. They have no symptoms. Unless they're leaking, there are no symptoms of these. Basically, ticking time bombs. Okay, so what do you do? What does this mean for us? Well, they're usually discovered incidentally, unless they rupture or leak or tear. And then in that case, it's a medical emergency. You have got to get that person to the doctor immediately. And the saddest thing is that of those people who are going to have a ruptured or leaked abdominal aortic aneurysm, 1 in 5 survives. The other 4 do not. My uncle died of this. He was male, he was older, and he was a smoker. And he had high blood cholesterol and high blood pressure. He was absolutely at risk, absolutely. Never was screened. We never figured out that he had it. And then one day he just, within 30 minutes, it was all over and there was nothing they could do. The risk of this type of thing happening, the rupture, is that happens when the aneurysm gets larger. Okay, and then it can actually increase over age. But sometimes the doctor, if it's small, the doctors will not want to do anything about it, and they'll just watch it and, what they call watchful waiting. If they're going to do surgery, so these are things that technically are over about 5 centimeters, 5.5 centimeters, there's 2 different types of surgery that can be done. And I could not find evidence that showed one was any better than the other. I think it really comes down to your doctor and where you can go and how good they are at doing each procedure. One point, they can actually cut out that bulge and bypass graft it, right? And they get rid of it. That's an open chest surgery. So they're opening you up, they're going in, they're doing this thing, as you can imagine. That's tough to get back from, recover from. The other thing's a little more clever. They stick a endograft, which is like a little device, up a catheter through your groin artery, because these things are all connected. They go up right through your groin artery, find the aneurysm, and they place this thing, which is like a tube that goes through the bulge and diverts the blood. And that kind of takes off the pressure and takes off the blood. Now remember, these bulges are actually filled up with cholesterol, and they're kind of like these mushy balloons in there. And so this endograft kind of strengthens that. So those are the two procedures that they do. Okay, I want to show you this slide as well because it has important things on it. Okay, so how do you get around this really scary aortic aneurysm problem? Reduce the risks. It's the same thing we've been saying. The diet, the exercise, stop smoking. Very, very bad if you're at risk for this. If you have family members with aortic aneurysm or anything, do not smoke, and reduce your stress. Control your diabetes, your high blood pressure, and your cholesterol. Particularly men over the age of 65 who have ever smoked need to have a screening. Okay, so we'll talk about that. One more slide. If you have the aortic aneurysm, like I said, surgery may be needed if it's over 5 centimeters. And there's been no advantage seen in these studies between 4 centimeters and 5 centimeters. And the reason they don't just go in and repair all of them, which, you know, to a point you're kind of like, oh my gosh, get this thing, you know, repaired. The surgery is tough, and it can have a risk of about 2% of death. So it's not something you want to undergo unless you absolutely are sure. And what I found was that specialty centers who do this with a lot of patients who are really proficient in this will have lower mortality rates. So it's probably really good if you or your relative is undergoing this surgery to ask about mortality rates. Don't be shy. Say, what is the mortality rate? And to look around and get the right center to have this fixed at. Another really interesting thing I found was that they're actually developing a vaccine against this if you're at risk, you know, these aneurysms from developing. And the vaccine is actually an immunomodulating protein. And if you remember way back at the beginning of this hangout, I was talking about immune cells entering into those plaques and becoming foam cells and the macrophages and the T cells. Well, this vaccine prevents that dysfunctional thing that happens by your body from happening. So that's kind of an exciting, development. Hold on one second. Oh, there we go. Okay, so screening. Really important to understand what is happening in the state of screening today. Almost every country does blood pressure screening as a routine. It's easy, it's fast, it's non-invasive, it's really easy. That's great. That's only a piece of the puzzle, as you've seen. There is available elective screenings. In particular, one company that I know about is called Lifeline Screening. And this is an elective screening. This is something you have to go and do and pay for yourself. But you do get a report that gets sent to your doctor. Lifeline Screening can screen for AFib, which is a risk of stroke, for carotid artery blockage, which we didn't even talk about, but also is bad and a risk for stroke, for peripheral arterial disease, and also for aortic abdominal aneurysms. Okay, so a number of these conditions that we've discussed today. It's a very reasonable price when you put them all together as a package, and it can be repeated as needed. It is non-invasive, it is painless. They do most of it through ultrasound and a limited EKG. But it is indicated only for people who have risk factors, so people who are at risk. So I probably wouldn't go because of, you know, the age and lack of risk factors. But if my uncle had been alive, I would send him. I'm sending my father-in-law risk factors. So they are definitely in that older group that has risk factors that should be screened. And another thing that I looked into that could be done are the body scans, which are the MRIs. But in my mind, you're getting radiation. You're getting a lot of cost. I mean, it could be upwards thousands of dollars, depending on where you go and what you do. And they're not even detecting AFib. They're just detecting some other things. So for these particular things, the screening, it's elective. So, you know, it was available in the US, it was available in the UK, and it was available in Australia. I don't know what's going on with the UK and Australia at this point. I think they're starting to phase those out, but you may be able to find other types of screening in those countries. Now that's it. Remember, you deserve to be well treated and treated well. Thank you guys so much for watching and for bearing with me with my technical difficulties. And remember, if you can watch the other How to Hack Healthcare series, we're going to be having a whole series of these. The next one, I think, is going to be on complementary therapies and choosing a good complementary practitioner, because it's, you know, it's not as regulated out there, and it's really hard sometimes to find someone who's good. So I've gotten a lot of information on that. We're going to be talking about that. And also, if you're having trouble or someone in your family is having trouble, please don't be afraid to reach out to me and talk to me. I do these webinars where I go through and I counsel people and I help them get back to their healthcare provider and to have conversations that will lead to diagnosis and treatment that they deserve. So I'm always available for that. Just email me. Ask me what that's about, okay? And or you can go to my website. My website's personalhealthinfo.weebly.com. Any feedback or suggestions is always appreciated. Whatever, just let me know what you want to see. I will produce a program on it, so if I know anything about it. And if not, I will find someone who does. I will get the information from them. Okay, thank you guys so much. Let me see. Okay, I'm going to wrap up the program, and unless anybody has any questions or chat or anything, but I don't see anything on here. So I'm going to wrap it up, and I look forward to seeing you at the next program. Thanks.